Thanks everyone for staying to the end. Not that there's wonderful weather that you could get out and enjoy this afternoon. But yeah, thanks for the introduction. My name is David. I'm a GP in the north of Glasgow in a place called Postle Park. But I've also been working as a researcher here at the University of Glasgow for about 15 years. And I'm going to be speaking about lessons from 15 years of the Scottish Deep End project, which I'll explain what that is as I go. And yeah, just in terms of declaration of interest, so you get a sense of where I'm coming from. As I said, I'm a researcher, so I've had various research grants from these charitable and state organisations. I'm now the co-lead for the Deep End project, so I have been kind of academic lead for about 9 years, but I'm trying to pass that on to one of my colleagues, and we're kind of sharing the role just now. I very much believe in transparency within medical research. So this website, Who Pays This Doctor, is a place that you can, put where your money comes from, and also positionality within research as well, particularly talking about socioeconomic disadvantage and other markers of inequality. I recognise my own privilege. And as I say, I work just 1 day a week in practice. It's an area of very, very high socioeconomic disadvantage in Glasgow, and I'm frequently in awe of the strength and survivorship of the people I work with. I also want to acknowledge many other colleagues over many years who've contributed to the ideas and the worked examples, the lived examples that we try to live by and demonstrate through our work. Also, we've had funding from the Scottish Government. We've had support, institutional support from the RCGP, which is the Royal College of GPs in Scotland, particularly to hold the budget where the funding goes and is held. But also the colleagues around the table. The Deep End Steering Group is a group of anywhere between 20 and 60 GPs. It sort of fluctuates over time, who've been meeting roughly quarterly for over 15 years. Initially in the evenings in their free time. Now we have meetings in the afternoon, but they've really been the beating heart of the project over 15 years. So what I plan to do is just to give you a bit of background and context. I think that'll be quite familiar to you, so I won't spend too long on that. And then I'll say a bit about the inverse care law and the origins of the Deep End project, and then a little bit about some of the impact that we've had in terms of policy, practice, research and education within Scotland, and to a certain extent in other places. Lots of scope for more work in this area, but some reflection on lessons as well. Yeah, this is bread and butter to you guys. What do we mean by health inequalities? I guess the main things are they're systematic, they're avoidable, they're unfair. But I think within our institutions in Scotland, we very much sign up to this definition. We recognise the role of discrimination and stigma in shaping some of our health inequalities. And as you've heard already, I'm sure we have some of the worst health inequalities in Western Europe. But while most of what the Deep End project focuses on is this kind of wealth inequality, socioeconomic inequality, and we also recognise that there are various other axes of variation and disadvantage. I'm going to end myself in this manhole behind me, and often they intersect. But again, this is familiar to all of you here. One way that I often think about health inequalities is shorter lives lived in poorer health, and we have quite a big body of researchers looking at multi-morbidity or people living with multiple long-term conditions. In this graph, it's the percentage of people with 3 or more long-term health problems. This is just a subset. So this quite influential paper published in The Lancet about 15 years ago now just looked at 40 health conditions. So it's a subset of many hundreds that we could potentially have looked at. But even with this subset of 40 conditions, you can see there's roughly 10 to 15 year earlier onset of multiple morbidity, multiple long-term conditions in our most deprived decile in the red line versus the blue line, the most affluent. Another big context here is that of austerity. Calling card neoliberalism follows an inverse harm law, where the impact of austerity varies inversely with the ability of communities to protect themselves against it. From inverse harm to inverse care. So one of our main influences, almost like our kind of intellectual and spiritual leader, if you like, was this GP, Julian Tudor Hart. Hopefully familiar to some of you. If you've not heard of him, I deeply encourage you to read some of his works. Tudor Hart was a kind of major figure, possibly the most influential GP in the history of the NHS. He's most famous for writing this paper called The Inverse Care Law, but he also was the first GP to measure the blood pressure of every single one of his patients in the practice. And he did that partly by good record keeping and what he called measurement of omission. So not only measuring what you are doing, but also what you're not doing. So he was able to, have a list of those that hadn't had their blood pressure checked, but also through relationships. And that was his probably core example, is the power of continuity of care, the power of commitment to an area, not only responding to people's immediate needs, but working with them over serial encounters to demonstrate that he cared, but also to help them to care about their future health. And he, in so doing, not just with blood pressure, but across a range of other issues, he was able to demonstrate a 30% reduction in mortality amongst his patients relative to a similar neighbouring practice. So the inverse care law today that manifests as a lack of time within systems to address needs. So here we have two measures of ill health. So the blue line is premature death, something that we can collect pretty reliably. And the red line is a combination of physical and mental health conditions, which are typically more complex than, for instance, collections of cardiovascular diseases, just as an example. So you've got this kind of gradient here, roughly 2.5-fold increase. And then in the black and the red, black and the green lines, you've got funding per patient and consultations. So to my mind, this is sort of the gap between where the needs are across the population and the resource, if you like, to be able to address some of those needs. We've updated this graph with more recent data just in the last couple of years, and the picture is actually worse now than it was 10 years ago. We have fewer GPs, fewer nurses, fewer non-clinical administrative staff in the most deprived areas versus the most affluent. So the inverse care law has exaggerated in the last 15 years. The Deep End project basically arose from that first graph. So we took that gap, flipped it to create a swimming pool metaphor analogy. So the idea is that practitioners, and bear in mind that this is a focus on practitioners, not on communities, really. But the idea is a kind of advocacy project for practitioners. That the practitioners are not only struggling to get to the bottom of the need, but they're also struggling to keep their heads above water. There's a mismatch in kind of resource to need, but there's also well-being impacts on the staff themselves. And the other elements of the flag, it's a flag to rally around, but it's got a sunrise or a sunset, depending on your outlook. The flag has a thistle on top, to say that it started in Scotland. And the green part of the flagpole is meant to look a little bit like a spurtle. A spurtle, for those of you who have never heard of the word, is a wooden instrument for stirring porridge. Okay, that's the Daddy Bear's porridge there. And the idea is that this should be an agitating project as well, an advocacy project. So that's the symbolism of the flag. Where are Deep End practices? Well, every practice in Scotland has a patient list, so we have a defined denominator, and we through this thing called the Scottish Index of Multiple Deprivation, which is an area-based composite measure of different indicators to reflect material disadvantage. You can calculate the number of patients or the percentage of patients who live in the 15% most deprived areas within each practice. And this is what you get. You've got roughly 900 practices, and you can rank them based on the percentage of patients who live in the most deprived postcodes. And that's essentially what happened in 2009. And the deep end was this sort of fairly arbitrary cutoff of the 100 most deprived practices. And just to give you a sense, so that goes from roughly, where I work just now, Paulson Park is 80%. So like 80% of our patients live in the 15% most deprived areas. The practice I worked at 2 years ago was roughly 40%. So you've got quite a variation within the deep end between 80% and 40%. And then you've got only roughly a third of every patient in Scotland is registered within deep end practices. The other 2/3 are across here, across the next 300, 400, 500 practices. So just a point to make that since the program has evolved and the project, the network has evolved, we've tried to move away from a focus on practices towards thinking more about what are the lessons for inclusive healthcare that can be shared across Scotland, and not just focusing on the top 100 most deprived. Our four main areas of activity are summed up in this acronym here: Workforce, Education, Advocacy, Research, or WARE. And we quite often think about another acronym called RAMP in terms of how we might attract staff to work in deep end practice, or what motivates staff. In fact, you can apply it to many, many other things. It's a series of constructs, particularly these three, which recur across different settings. So it's been used in gaming theory about what attracts people to different computer games. It's been used in business in terms of what motivates people to work for your company, work harder. It's part of self-determination theory as well, uses three of these four constructs. So they're quite kind of frequently recurring constructs that I think can be quite helpful, particularly when you're thinking about recruitment and retention of staff to areas that are underserved. I think I hinted on this already. So SIMD looks like this. If you put in any postcode in Scotland, you'll get a kind of spread like this. It's across 7 different domains. The big 3 are income, employment, education, but we've also got various indicators for the domains of crime and health itself, geographic access, and housing is the 7th. And 80% of deep end practices are in the Glasgow area. So there's a bit of a concentration of the network, which I think from practical purposes in terms of face-to-face meetings makes it a little bit easier to organise. We know a fair amount about the kind of typical challenges, and again, this will be no surprise to any of you here, but all of these issues in high volume, essentially, and so lots of issues with poverty, food insecurity, fuel insecurity, lots of issues with drugs and alcohol as a result of that context, child protection, vulnerable adults. NCD is non-communicable diseases, so basically any long-term condition, whether it's chronic pain, cancer, respiratory, heart, liver, obesity, neurodevelopmental conditions, and pretty much all of these have a strong socioeconomic gradient where we see them in higher volume. Lots more migrant health. Interpreter consultations take twice as long, pretty much, usually. We don't have any extra funding for that, for example. We have, as you heard, reduced life expectancy, reduced healthy life expectancy, and bereavement at a younger age. Right? As a direct consequence of that, we see more deaths of people in their 40s, 50s, 60s, which have a bigger impact on the social fabric of those areas, those families, than the death of my granny, for instance, in her late 80s. And we know quite a lot about the consultations as well, and that pretty much maps on to what I was saying before about the swimming pool analogy: higher stress, lower empathy, which is a crucial mechanism, and lower enablement then as well. So the idea that if you have had a consultation and you're asked afterwards how confident do you feel to manage your health problems, that's the concept of enablement. And we see lower levels in more deprived areas. I don't know how many of your sort of primary care backgrounds, but this lady, Barbara Starfield, is often held up as a sort of key figure within primary care, although she was a pediatrician in the US, not necessarily a family doctor, but she articulated the 4 C's of primary care being first contact, continuity, comprehensiveness, and coordination. There's been additional elements added on: family orientation, cultural competency, community orientation. I've added measurement of emission, but I think the original paper had planetary health down there as well. And I guess there is a reasonable body of research evidence showing that countries and areas which have stronger primary care tend to have lower health inequalities, better health outcomes. Yeah, I think I don't love the term cultural competency. I think cultural humility is preferable, and ideally structural competency is where I think we want to be moving towards. I think that this, for me, is just to make the point that we recognise within our group that the inverse care law is not just about the distribution of resource, but it's also about how that resource is navigated and how people access and engage with services. And we quite often use this theory called candidacy, which I think is quite helpful in highlighting the dynamic nature of interactions that people have with healthcare. And obvious examples are, if you've had a negative experience with a healthcare service, as many people do, that is likely to influence your help seeking and your interactions in future. But there's all these other elements to the candidacy journey, if you like. So the starting point is you have to identify yourself as a candidate for that service, whatever it is. And often that's the first stumbling block, because you might not be aware of the service. You might not think that you're worthy, so you might have crippling anxiety or low self-esteem, low self-confidence. So often some of the work that we've been doing is trying to almost kind of assert people's candidacy on their behalf and build that trust and that confidence up to demonstrate that they're, warrantable and eligible candidates. There's various elements of navigating services which can be more or less problematic. You've got to have a degree of health literacy to appear at a service and assert yourself and make the case. There's an adjudication process that goes on from health professionals. There might be resistance to services. And then there's this kind of whole slightly nebulous area of operating conditions, which, for us encapsulates all the various competing demands, both on individuals and families, but also on the system itself. I've got one slide about missingness. It's just really to highlight work done by one of my colleagues, Andrea Williamson, who's also a deep end GP. And her research has shown that people who miss 2 or more GP appointments in a year are at higher risk of premature death. That's particularly the case for people with mental health conditions. This is all-cause mortality is roughly three times increased for those who are high levels of missingness. But for those with a mental health condition, it's 8 times. So eight times risk of all-cause mortality for the high missing group. And I guess what that's highlighted to policymakers and practitioners in Scotland is that missed appointments should be reconceptualized as a risk marker, a red flag, if you like, rather than something which should be punished, either by fines or by being removed from a list. And our work that Andrea and colleagues have gone on to do is to kind of really articulate what the various causes of missingness are, and to start to suggest what some interventions might be to improve engagement, and both partly from an individual level, but largely from a system level. Okay, I'm conscious that some people might need to leave at 4, so I'll kind of try and get through these reasonably quickly so there's time for discussion. Essentially, we started in 2009. The starting point was basically identifying deep end practices and inviting them to a meeting. And then there was a series of phases, if you like, of common purpose, sense of identity, and then we had lots of roundtable meetings describing some of the challenges, and then tried to move to what might solutions be. So these projects here kind of all followed the sort of initial sense-making work and problem identification work. And I'll say a bit about some of these just now. I mentioned that 4 areas: workforce, education, advocacy, research. Yeah, just to start, the workforce challenge has been this context of imbalance within the NHS system, whereby we've had decades of rhetoric saying we need to shift resources closer to communities, but the opposite has happened. So we've had hospital consultants going up like this across the 4 countries of the UK, and GP numbers flatlining. And it's worse for some other parts of it. If you look at district nurses, for instance, other parts of the community workforce, it's even more stark. Because of these declining GP numbers in Scotland and in many other countries, we've tried to plug gaps with expanded multidisciplinary teams. So we now routinely have pharmacists and physiotherapists working in practice. Within the deep end, we've had community links practitioners, welfare advice workers, now pretty much in every deep end practice. We've also had smaller pilot projects of having social care workers, alcohol nurses, mental health nurses in some places. None of those have been mainstreamed or rolled out more widely. But where they work well, they work flexibly, they're part of the team, embedded within the team, they get to know other members of the team, including the frontline admin staff, the very front door, on a named basis. And that kind of relational element is a big part of it. In terms of education, again, we tried to look at different stages of health workforce careers. Done a little bit of work supporting some of the widening access initiatives to make the workforce, certainly the medical workforce, a bit more representative. Still quite a long way to go on that. And we've done different things at undergraduate, postgraduate, and kind of lifelong learning stages. And in fact, there's some new funding has been promised for general practice in Scotland just in the last few weeks, and as part of that, we're likely to see more health equity fellowships being implemented. I guess I said right at the start about the spurtle, the agitating elements and the advocacy elements, and I guess just to make the point that not every deep end GP views their role as having any advocacy element. So pretty much everyone that was interviewed as part of this PhD recognised their remits within clinical care and social issues. Most of them saw some sort of community-facing responsibility, but not everyone was at all interested in policy and politics. But for those that are, we've organised media training, we've organised petitions to MPs on different issues, and we've tried to at least tentatively work with other like-minded networks like the Poverty Alliance. In terms of research, we are mindful of the fact that marginalised groups are often excluded from research. Pretty much all of our healthcare research guidelines, checklists, whatnot, are based on research which systematically excludes older people, poorer people, in Scottish context, non-white people, where encouraged by the NIHR's move towards inclusive research design, but there's a huge way to go on that front. And I guess we've also used the idea of practitioner experience as a form of evidence. It's not as high quality as research, but with these kind of round tables where we maybe have a dozen folks around the table. In the early days, that would be pretty much exclusively GPs. Now we're moving much more towards at least, half deep end GPs, half other stakeholders, whether that's third sector or patient voice or policymakers. We try and have a bit more of a wider stakeholder group. But we can have quite a quick turnaround of these roundtable reports, summarise them within a month, and disseminate them proactively to policymakers. And I think I would say we're starting to have some impact. Obviously, I mentioned the links workers and the welfare advice workers, which are now across all practices, but we're starting to see some of the ideas implemented in reports like this, but also in some additional funding. So quite recently, we've had Inclusion Health Action funding, which was partly to address missingness. So there was some funding streams around more proactive engagement, longer consultations with certain more complex groups. There's part of that was around training, and part of it was around patient engagement. And I guess just the final thing to say, because that is now 4 o'clock, is just the notion of proportionate universalism. So services like health, services like education, which are universal across the country, we would like to see this principle of proportionate universalism being applied. So the idea that it's not just a one-size-fits-all, and that we try to measure needs and then resource according to that need. Again, a long way to go, but reports like this start to articulate how that might happen, and I think have been pretty useful. And that's my last slide. So yeah, inverse care law manifests as a lack of time and resource, and there are various additional needs and issues in deep end practices. I mentioned missingness. I've not really talked about trauma-informed care, but that's a huge part of our daily work. There's some need for protected time for professional development. There's need for attention to team well-being, because if you've got a dysfunctional team, and many of our practices, it doesn't take much to imbalance them if someone's unwell or off for another reason. We need to have mechanisms of sharing learning. We need to have capacity for advocacy, and we need to involve patients and communities more effectively. Yeah, and just final one to say, start in Scotland, but there's now different deep end groups across the world, mostly across the UK, but there's one in Japan, Australia, Canada, Denmark, a few other places. So it's becoming a bit of a kind of global network. Thank you.
Thanks, David. Yeah, we're some people have to run off. We've got a wee bit of time if people have questions for David.
I've got to head off, but I wanted to ask a question because when I was speaking, we're talking about there's this brilliant work which is highlighting what the issues are, and yet, and I know in kind of my area of sort of community development, there's a lot of overlap, and it relates to this idea that we keep saying we've got to use preventative spend. So there's the wellbeing economic lives talk about the kind of failure cost kind of thing, the kind of these failed policies cost a lot, and yet we have not shifted that. As you point out with it, we've not been able to shift the investment up or even increase it, because this is a frustration for me. It's like there is not a finite budget. There is actually, these decisions are made, as we see with us, for what we spend our resources on. Yeah. So there clearly is a kind of ethical and moral dimension to which we should be investing and engaging with those. There should be policy coherence to say if you're, we've taken the UNCRC into Scottish law. So that's the idea that young people getting right for every child is one of our policies. It's the complete opposite, frankly, of what we do.
Yeah.
So I'm just interested in a group like the Deep End who are culturally powerful. You've got a lot of cultural capital within those groups. Why do you think the system is so resistant to actually shifting resources in that way?
Yeah, I mean, it's a great question. Totally agree. I think there is always, vested interests that are resistant to change, and I guess we've even seen it in the last few weeks, whereby we've had probably our best opportunity ever for trying to shift some resource within general practice just to more deprived areas, and actually the Scottish Government seem to be for it, interested, but it's the BMA negotiators, the doctors, the GPs that are negotiating that are a bit more wary. And I think it's that kind of, I guess, whether it's risk aversion or sort of conservatism or not wanting to rob Peter to pay Paul. I think there's a real reluctance there. So we're hoping to, meet with that leadership soon and just hammer home the case that if you're not going to do it now. I think previously they were saying we can't be seen to be putting any extra resources into deep end practices if other practices are going to struggle or lose out. And so the argument was, we need to wait until we have additional investment across the board. But now I think we kind of do have that, so we need to see that proportion universal. And the other challenge is a practical one, is that I'll leave it there. But basically, we don't really have very good data on needs within areas or within practices. So there's some practical challenges of trying to say this is a better formula than the one that we're currently using.
So I need to get my because my ticket's up in my car. But the interest, because in education, the education policy did a thing called Pupil Equity Fund, where they tried to attach more money into poorer areas to improve the educational outcomes of young people. But there was very little tracking of that, how that money was spent. And then there was an extent to which it was just used to fill gaps. So you say, right, we're going to target this, we're going to give you this money. And they say, oh, that's great because we've cut on all these other things. So you don't get a true, even when there's a recognition that actually more resources in these areas can be beneficial, the wider system then kind of corrupts that approach. And then you say, oh, it didn't make the difference, and so you can use that about. So thank you so much. I find that really interesting. It was great to see you guys. Hope to see you all sometime soon. Tony, I will see you. So I'm sorry to pass the dash off.
Thank you.
Yeah.
Any other questions or comments to raise?
I think my question is just a follow-up to what you were saying about not having any data. Do you think it would be helpful to kind of carry out research in that kind of area, or is it just more on the practical side of things?
I mean, there's almost certainly need for more research. I think there's a fundamental challenge of you only have the data that is based on this reality. Hang on, let me just get you to the slide. Going like that. So if this is our starting point, right, and we know that practices aren't really meeting needs, then you can only really measure activity.
Yeah.
So what we're wanting to get to is to say, and actually we have one example in Denmark where they're trying to do this. They're trying to say, and they have better data, so that they're able to look at individual level data related to education level, health problems, income, language needs, a much more kind of multifaceted picture. And what they're proposing is that rather than looking at funding, which, as we know with our current, what's called the independent contractor, basically every GP partner is a private operator, then there are some practices that can profiteer by delivering a poor service with minimal staff, still make lots of money. So there's issues with the way that the independent contractor status works. But what they're trying to do in Denmark is say, actually, if we take it from the WHO, for instance, would recommend 1 GP for every 1,000 people, right? And they would say, okay, that's the starting point, but maybe in the deep end, you need to have 1 GP for every 900 or 800.
Yeah.
And in a more affluent area, you might just have 1 for every 1,200 or 1,500. Okay, if it's a university population, 1 GP for every 2,000 might be fine. So they're trying to use more of that kind of ratio of practitioners to population.
But bring in some context.
To bring in that context and that patient complexity. But I think it's just quite challenging to have an agreed upon set of measures which is based on real populations, kind of almost in real time, which isn't just measuring activity, but it's trying to in some way measure needs and unmet needs. It's complex.
Yeah, I was just kind of saying that because I know that research does tend to attract funding while also needing funding. So
yeah,
I don't know if I understand it's complicated, but I was just wondering if these things could happen, maybe they could help.
Yeah, so there is a research team in Manchester that are looking at the English funding formula. It's called the Carr-Hill formula. So they're looking at that just now. Myself and colleagues in Scotland are in touch with them, trying to work out how they've done it. We're in touch with the team in Denmark, they've really managed to shift some resources from hospitals to communities in quite an impressive way. I think they've met some struggles as well in terms of signing off on the final proposal, especially that weighted, this practice should have 900, this practice should have 1,500. That's met resistance.
Which is the name of the formula?
It's in Denmark. I don't know if they've got a name for it. It's just what the primary care negotiators of the new contract in Denmark have proposed. I can send you some more information about it. Oh, the English one is called Carr-Hill. It's named after someone called Carr and someone called Hill. I don't know. Yeah.
Any other last minute questions?
I just want to say that individual data are important for sure to identify some important area where or important people where to concentrate yourself and your action, but also it's important to not do the mistake of considering them or having an individual approach of the problem, because otherwise we repeat the same error, the same mistake that like the common way of seeing health do. Considering individual problems and
Yeah, I mean, I agree with you. In fact, one of the projects that I'm working on just now, which I'm quite excited about, is called a family wellbeing worker. And this is a role which we've never had before in general practice, which is similar to the links worker, community links worker, but the focus is on the whole family. So the links workers tend to see adults pretty much. And the family wellbeing workers have come from a background of working with children and young people, often children involved in crime or children involved in addictions. And they take a real family approach, but they also have additional funding for a range of different wraparound supports, whether it's financial advice or food insecurity, pantry vouchers, different things, language supports, trauma counselling support, a whole kind of range of different things. That for me is quite exciting because it also makes us think differently about even how we collect data about the family and how we can capture families within our systems. But it's also made some of the other partners in the project. So we have an organisation called Glasgow Life, which runs our libraries and our gyms and other community venues. Glasgow Life are part of this small pilot, but they have also changed their way of thinking from that kind of adult to adult model towards thinking about families, which I think is quite exciting.
Yeah.
Another point.
No, nothing.
I think just to finish, I'm just going to ask about the thing you mentioned about like the policy and advocacy sort of side. I suppose what for you is kind of what's worked with the GPs at the deep end in that sort of side? Is it the kind of fact that GPs don't feel that they're putting themselves in a position that they are taking the heat, that it's kind of everybody takes as this kind of organisation sort of thing? Or again, is there other things that are kind of particularly effective or have been effective for GPs at the deep end and have a little bit of sway in the policy level?
Yeah, I think it's partly that first point, Tony, about feeling that it's not you as an individual GP sticking your head above the parapet on an issue. It's having that kind of more collective backing towards advocacy, really, whether that's about agreeing to an interview on the radio, or whether that's about turning up or being, invited to a Scottish Parliament committee meeting, and I guess for whatever reason there is now I guess quite as Mark was saying, sort of cultural capital within the network, where we would get invited to contribute to a consultation, or we'd get approached by different media organizations for an opinion on this or this. And I think it's difficult to say exactly how that evolved, but I think probably having that combination of a reasonable pool of like-minded practitioners with some academic time and support as well has facilitated that, with media training as well. I think that makes you more confident to have that advocacy role.
Yeah, I think that can tap into some of the conversation we had over the weekend. I'm conscious of time, that's just 17 minutes past, so I think we'll wrap up and people have to make their way, including David. So yeah, just to thank David again for his time.